So our next topic will be CEUS for interventional procedures, and EFSUM, the European Federation of Societies for Ultrasound Medicine Biology, has just published on ultrasound-guided interventions. And the role of CEUS for interventional procedures will be explained by Christian Nolsoe, who is the former EFSUM president and president-elect of the World Federation of Ultrasound. Christian, I'm very much looking forward to get your guidance on CEUS for interventional procedures. Thank you.
Thank you very much, Christoph, for this kind introduction, and good afternoon to you. And good afternoon to the audience out there, which I cannot see, and this is actually quite exciting. I hope there are many of you and that you can hear me. I will not hide. This is my first experience with this kind of lectures. I have been given hundreds of lectures around the world, but this is the first time, so I hope you will have a good time. Anyway, I will talk about CEUS for interventional procedures, and I'm a radiologist, but I work in a surgical division at this hospital in Copenhagen, which is the highest building in Denmark. It's quite small, seen from the aircraft. I have a question to you to start with that you can think of during my presentation here, and that is what is going on this image here. You might guess it or you might not. I will talk about CEUS for guided intervention, but I will also include fusion, because what I will share with you is my daily work, and the work I do is a practical kind of work. So I use CEUS, but I also use fusion. And for practical reasons, you can talk about different indications for using these gadgets in our new interventional box. That could be we need to do a biopsy of an invisible lesion, that is, you cannot see it with B mode, or you would like to identify lesions that are easier to biopsy than the one you have seen on CT or MRI. You need to biopsy from viable areas to avoid necrotic tissue. You might want to improve your visualization of fluid collections. You can substitute an X-ray contrast study with an CEUS physiologically and thereby spare the patient for X-ray. You can use it in ablation guidance, and you can use it to monitor bleeding. I will not go into details with all of these areas. I will show some of them. First, let me show you a typical example of a typical metastasis with a typical CEUS. In this case, you actually do not need CEUS or fusion. You can take a biopsy on the B mode because everything is so clearly visualized. But sometimes you actually do have invisible lesions that somebody else wants you to biopsy. Now, when I say invisible, you cannot biopsy something that is invisible. So, for instance, here is an old image showing this is a CEUS on the left and the simultaneous low mechanical index B mode on the right side. There is a lesion here that you cannot see on the B mode. This patient might have had a biopsy, might have had CT or MRI where this lesion was seen, and they ask us to do a biopsy. Now, we will not be able to do the biopsy if we only have the B mode. That is why we need the CEUS. Here's another case. This is a breast cancer patient. There was a PET positive met in the liver somewhere, but where is it? You have a liver here, you have the right kidney. Somewhere here there is a metastasis. I cannot see it. What I did was, of course, inject contrast agents, and if you just look a little carefully, here comes the metastasis. So something that you cannot visualize on the B mode, you can now clearly see on the CEUS study. And you can measure it, and if you can see it this clearly, you can also do a CEUS guided biopsy. And when I mention and say CEUS guided biopsy, I actually mean that you can do the biopsy real time in CEUS mode. Here's another case. This gentleman was referred to us, 60 years old. He had elevated CEA and there was ascites, and they wanted us to do a biopsy if we could find any focal liver lesions. This is his B mode liver study. You can see the ascites, you can see the liver tissue. There is no lesion that you can visualize on B mode. After giving contrast agent, we were very surprised to see that actually this liver was heavily infiltrated with diffuse metastasis that was not visible on the B mode, but guided by the CEUS study and with simultaneous study, it is possible to do a CEUS guided biopsy, and the biopsy showed that this was indeed colorectal cancer metastasis to the liver, which was also suspected. Now, here comes a little of the fusion, because sometimes CEUS is actually not enough. Here we have a fused CT CEUS study, and here it's a fused CT B mode. You can easily see the lesion on the CT. You also know that these kind of lesions may be difficult because it's high in the dome of the liver, so the access can be very difficult. And indeed it is. With ultrasound, you have the pleural and lung interpone space coming down here, so you barely see the lesion. You know the lesion is up there. You can see it on the combined CEUS and CT fusion. And because you know it's there, we were able to do a guided biopsy, and actually it came out it was a breast cancer metastasis. And since this patient had 2 cancers, this biopsy answer was very important, so she could receive the correct metastasis. So sorry, the correct chemotherapy. Now, what is fusion and how does it work? Well, fusion basically is you combine 2 sets of data and put them on top of each other, just as you know from the weather forecast. You have geographically information, you have weather forecast information, you put them on top of each other, and that is a fused image, the weather forecast. Exactly the same is what happened when you have CT ultrasound fusion. You have the ultrasound image here, you have previously acquired CT scans that you put into the ultrasound system, and now we have a technique that merges real-time ultrasound with previously acquired CT, PET-CT or MRI. So now ultrasound is the master and CT is the slave, which is a good situation for us in ultrasound. You can fuse it with PET-CT, you can fuse it with MRI. And actually sometimes you do not need CEUS. In this case there was an abscess after a cholecystectomy. It was impossible to see on ultrasound because there was air in the area, but because we knew there was a CT study, we could do a fused ultrasound CT study, and in that case we were able to drain the abscess without really seeing it on ultrasound. All you see is the gas there, and you can do an abscess drainage with fusion ultrasound. I will use this later when I show you how you can use it for ablation and for substitute of X-ray. Another very important indication is when you do a biopsy, you need to choose the right area to take the biopsy. This is also in our guidelines, in the WAFOM, EFSOM guidelines for use of contrast agents for the liver. I think you all know that in the center of metastasis, when they are this big, there is very often a central area with necrosis. If you take a biopsy, you should avoid necrotic areas. They are maybe not always in the center, so you cannot see this on the B mode alone. This is another case. There was a huge tumor, and there was done a previous CEUS study in our department. It showed only necrosis. They took a biopsy, and the biopsy also showed necrosis. So the patient was referred, and a second CEUS study was done. And carefully looking, you might be able to see there was this area coming up here, which was actually perfused. So this is the viable area, and this is the area you want to go for with a biopsy. And this is a CEUS guided biopsy, real-time CEUS guidance. You can see the needle coming down here on both the CEUS image and on the B mode image. You can see the needle sampling from the perfused area. And here is on the right, you have the necrotic biopsy area. The biopsy was taken in the center, which is not wise to do, but when you only have the B mode, you might not know. When you have the CEUS guidance, you can take it from the viable area. You get the diagnosis, necrotic area, but also viable tissue, and this was a CCC, cholangiocarcinoma of the liver. There's another nodule. It looks small and very well defined. You may not suspect there would be necrotic areas, but actually there was necrotic areas. So this small area up here was without contrast agents uptake, and if you take the biopsy from here, you would get necrotic area. The biopsy was taken from the perfused area and the diagnosis was an HCC. This has also been shown from this well done study from China and Wu. They showed that you can have a diagnostic yield increased by 10% if you use CEUS to guide your biopsies. You can also use CEUS in another way. Instead of looking for the washout area, if you use sinusoid, you can use a different algorithm to characterize focal liver lesions in a cirrhotic liver. And actually what you look for here is something that is enhancing in the post-vascular phase. So when you use sinusoid, you have a post-vascular phase, and you can use this to diagnose HCCs in a cirrhotic liver. This has especially been studied very well and published a lot from the previous work from President Masatoshi Kudo. And you can also utilize this in interventional cases. So what you do is, when you have a lesion in a cirrhotic liver and the lesion is still enhancing after the usual 2 minutes, if you use sinusoid, you might also see it is enhancing even at this late case. This is 30 minutes. It can even enhance and be ISO enhancing after 30 minutes, and it's still suspicious of a HCC, of a well-differentiated HCC. Now you can use the CEUS study to take a CEUS guided biopsy with sinusoid. In this case, it turned out to be an HCC. Another indication for using CEUS in the interventional work is to substitute X-ray contrast study with a CEUS study. In that way, you spare the patient for having X-ray, and this is a good thing to do. So one obvious indication is if you drain an abscess, like in this case, there's an abscess here. We have put down a catheter. You can see it coming down here. Now, after you have emptied some pus out, you inject through the catheter contrast agents, and you can see that there is one well-described compartment, and the contrast is filling out the whole compartment, so you can believe that you have drained this abscess well. You can use it also in other hollow organs or in tubular structures. This was a patient who had a Klatskin tumor, that is a central cholangiocarcinoma. You can see there is dilatation of the intrahepatic bile ducts. We have a needle in here, and there's a guide wire put in, and over the guide wire a catheter is inserted. Now on this catheter we inject a weak dilution of contrast agent, and you can see that the bile tree is filling up. You can also see the entire bile tree intrahepatically is filled up, but nothing is escaping from the liver. So here is a case of total obstruction. A similar case, but in this study there was a sort of an heterogeneous mass, and the patient had symptoms of an abscess, so we suspected it could be an abscess, even it was not the typical appearance in B mode. We did a diagnostic puncture and pus came out. After that, we put in a catheter and again injected contrast agent on the catheter, and you see the abscess is filling up. In this case, we were able to follow the common bile duct filled with contrast coming from this abscess, and you could even follow the common bile duct into the becoming the choledochal duct and all the way down into the duodenum. So in this case, we alone with ultrasound could prove there was an abscess and there was communication with the bile tree, but there was also open and it went all the way down into the, so there was no obstruction all the way to the duodenum where we were able to follow this contrast. Finally, CEUS is heavily used in all phases of ablation, guidance, monitoring, and control, and I will not go into details because the next speaker will do that. But it is in the guidelines that CEUS can be used for biopsy planning, but also for monitoring of ablation treatment. And one good point when you do ablation is that before you have the patient in the OR or wherever you take him to do the ablation, it is a good thing to do a thorough study so you know exactly where the lesion is and how you can access it with the needle. Because if you do it with like we do, the patient is in full anesthesia, there is a totally different lie of the liver, and it can be difficult to identify the lesion. When you do the first study, you do it with a patient that is awake, and he can voluntarily help with the respiration. When you get to the OR, this is not the case. So I always do a note for myself that this, for instance, in this case, there is a small metastasis. It can actually only be seen on the CEUS study, but it is easily seen in the lateral left position with a normal breath and in the intercostal space at between 9 and 10 in the anterior axillary line. In that case, I will be able to go back and find the lesion also in the OR. Then you can do the delivery. During that, you have not much use of the CEUS, because if you use RF, you will have a lot of noise. And what you are actually more interested in is just immediately after you have fulfilled your ablation. In this case, we are doing a CEUS fusion case. So you have the fused CT here. We have a GPS marker telling us this is where the lesion was when we began the ablation, and you can see there is something still taking up contrast, so it might be suspicious of a skip area. So immediately during the procedure, we go on and we use the GPS marker to do a second ablation at the same time. And after that, there was no skip areas suspected on the BEMO and the CEUS, and then the procedure was considered done. You can also full advantage of having fusion GPS and CEUS, and you can do simultaneous ablation of more than one tumor. This case was a very rare case. We did actually, this patient had 6 metastases, and with microwave you can do more than one at a time. So we have 3 microwave machines, so we actually ablated simultaneous 3 metastases using fusion and CEUS guidance. It looks difficult, but when you have all these GPS positions on the tumors you are ablating, it is actually not as difficult as it looks. For the follow-up, CEUS is a must. So whenever you have in your lab, ultrasound lab, a follow-up of ablation, you should use CEUS, and you want to see this very sharply demarcated ablation cavity, then you are satisfied. If you see something like this, you have an irregular ablation cavity, you can see there is also something taking up contrast. Again, you can use a CEUS guided, real-time CEUS guided biopsy from the suspected areas, and we did, and this was local recurrence, and the patient was re-referred for another ablation. We have used this approach and published it for this material, 125 metastases. We had 100% technical success with this approach. Now, if we look a little to the clinical outcome, actually, there's a very encouraging paper that came out of South Korea in April 2011. They had a huge material, and they showed that of the patients, 226 patients with a single metastatic tumor, and if the tumor was less than 3 centimeters, the overall survival and the disease-free survival was no different between the operation group and the RFA group. More specifically, the 5-year overall survival and the disease-free survival rate was 51% and 33% in both the RFA group and in the resection group. So I think for the future, the question should be not who should be offered, but rather who should not. We should be much more aggressive. And so we are, because the next generation of ablation is coming into our labs now, and that is the nanoknife. Totally different approach. It's not working by heat, it is working by high voltage, and it implies, it's called a reversible electroporation. It implies inserting up to 6 or 7 needles simultaneously into a tumor. And now, I'm sorry, I can't cut out this sound, but you can see here, this tumor is running right, it's encasing the mesenteric superior artery. You can see here how the electric voltage makes the needles move. And this is, sorry about the noise, I couldn't get it out, but this is immediately post the nano ablation. You can see how there's an ablated area surrounding the still viable mesenteric, no, this was the trunk, celiac trunk. So we want to preserve the major tubular structures like the artery and like the common bile duct or like the pancreatic duct, but we at the same time destroy the tissue in the cancer that is encasing these structures. So this is very promising. And recently there was published this paper from Dr. Martin's group in Louisiana, and very encouraging. They have a mean overall survival of close to 24 months for locally advanced pancreatic cancer, and this is more than a double of what is standard for chemotherapy and chemoradiotherapy. Finally, I want to call your attention to the fact that we can also use CEUS in the monitoring of bleeding, and bleeding may be a complication to our interventional work. It can also be in the trauma center, but CEUS is very good for monitoring bleeding. Here's a case. This is an irregular liver. You can see there's a rim around the liver, and this is half an hour after we took a biopsy, and the patient actually did have pain. This is actually fresh bleeding around the liver, but that can be very difficult to see on the B mode alone. There's a similar case. This is just immediately, it's not after, this is actually ongoing microwave ablation. You might see there's a little bit of fluid collection up here. This is a lesion, this is a needle in there, and this is the answer to the opening question. What you saw was blood pouring out through the hole at the surface of the liver where the microwave needles entered. And you can see ongoing fresh bleeding. You can see the bubbles in the fresh blood. Now just look carefully, because 5 minutes later, the bleeding has ceased. No more bleeding. It looks exactly the same. It's still black on the CEUS. It looks exactly the same on the B mode. It looks like the liver. But on the CEUS, you can easily see that this coagulated blood is not taking up any contrast agent. So CEUS will save you from missing the diagnosis. On this B mode, you might miss the fresh blood clot because it looks very much like liver. On the CEUS, you will never do it. Again here, fresh blood clot, easily seen. So CEUS will change your way of seeing and help you not miss the important diagnosis. Conclusions are very easy because there are numerous indications, and it's a matter of using your imagination because there are still numerous indications not being investigated. Intervention is a great game also for Danes. Thank you for your attention.
Dear Christian, thank you very much for that excellent and comprehensive talk on CEUS for interventional procedures. So what are the advantages, if you could summarize in reference to computed tomography, which can also use contrast applications? So could you comment a little bit on that?
I think I can just, it's very easy. The real advantage is that we do it real time. We can do it over and over again. If you didn't see if you missed something on a CT scan, you missed it. If you were too late with your timing, your gating, you didn't see the arterial uptake or whatever you looked for, you missed it. With CEUS, you can do it over. You can do it actually in the same infusion, in the same bolus, because you can do a burst bubble procedure by pressing high mechanical index, and you can see the arterial fill come in. Or if you're not able to do that, you can re-infuse again. So it's a real time, and it's a possibility of putting your needle exactly where you want it at any angle.
Thank you again. So I do not see any question coming in. It must be impressive, clear what you are telling. It was conclusive, and thank you very much again, and have a beautiful time during your vacation. Thank you very much for being here for our webinar of EFSOM. Thank you.
Thank you, Christoph. Thank you.